Hey, we're the Turd Nerds. We're glad you're here. Before we take the plunge, let us introduce ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and licensed acupuncturist specializing in digestive, microbiome, and hormone conditions and integrative fertility.
I'm Dr. Ami Kapadia. I'm a medical doctor trained in family medicine and functional medicine with a special interest in combining standard therapies with lifestyle and nutrition-based interventions.
And I'm Dr. Alana Gurvich, a naturopathic physician, licensed acupuncturist, and a fellow of the American Board of Naturopathic Gastroenterology. I specialize in IBD, IBS, and other functional GI disorders. Let's dive in.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Welcome back, Turds. We are happy to be here, and today we're talking about something that is very important to a lot of our patients. It's getting off proton pump inhibitors, how we do that and why. And I think we're going to be talking about some cool study as well. So studies, even better. Where do we want to start?
Well, and I just wanted to mention to you guys, my one published article we had to do in residency. I think we were required to do one publication. So me and my friend and one of our senior residents or attendings actually published an article on the adverse effects of proton pump inhibitors, where we did kind of a review article.
Was there a lot out there at that point?
We were way ahead of the time, Rebecca.
I believe you.
I was always looking for problems from medications.
Yeah.
Well, and then what year was this?
This was around 18 to 20 years ago. I do not know the exact year.
So like early 20,
no,
early 2000s.
Probably 2008, 2009, I would guess. So actually more like my timing's a little off here. So probably 16, 17 years
Wow.
ago.
I mean, that was because I remember when I can remember when it was all about like the little purple pill came
I
up,
know.
which was the
Yeah.
first ever
Yeah.
proton pump inhibitor, right?
Yeah.
Nexium
That's
changed
right.
before
That's
that.
how
What
they
we had was
advertised
H2
it.
blocked it.
Yep.
Yeah.
I remember that. And so I must have been like either undergrad, I was probably in naturopathic school.
Yeah. Yeah.
Yeah. Well,
So-
you were ahead of your time.
Yeah. Well,
Okay.
it's been a while.
Does that
So-
surprise anyone?
Definitively, every clinician and a large amount of patients
Yeah.
walk into their doctor's office,
Yep.
complain of reflux.
Complain of any upper GI
Just
condition.
the-
And some lower GI conditions, really.
And then
yet-
the doctor says, I want to help.
Mhm.
They give them this prescription. It's magic. It's very effective.
Yep. Have you guys taken them?
I've never taken
No.
them.
Wow, really?
Well, because I don't know if this was that article or later on, when I was reading of all the adverse effects, even
Yeah.
in shorter time
you got
frames,
through medical school without taking PPIs?
You
have to be
knock
a
on wood,
small
have not
subset.
reflux.
You did not. You took them.
I took them. Yeah, I was worked up. I had bloating forever.
Yeah. Your
And,
GI does not move.
upper GI, they gave a PPI. Did it do anything? No.
It didn't do anything.
There was maybe a placebo in the beginning, but
Because
that
most
wasn't my
patients-
issue. Yeah, I didn't
A lot
have
of people.
acid problems.
So the problem with PPIs is there is very clear data that it has efficacy
Mhm.
somewhere between 6 weeks and 3 months. Is that how it's being used?
No.
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 I mean, I have patients who have been on PPIs
Decades.
forever.
10
Yeah.
years.
What
More?
should we talk about the indications for when you actually should be on
Yes.
a PPI?
Yeah.
So if you have Barrett's esophagus, right?
Yes.
It's the only condition where
It's
that's
not
changing
mandatory
some.
anymore.
So they
Yep.
changed it.
It's
We talked
conditional.
about-
Yeah.
So
it used to be. I mean, I think we all learned, like, if you have Barrett's, you're on PPIs forever. And they have retracted that.
I think you told us
Yeah.
that last year, and I
Yeah.
forgot.
So,
So is it now for a defined period and then you see, or
that's a
it's-
good question. I don't
okay, we'd have to look that
know.
up.
Yeah.
And then if you've had a recent, of course, ulcer.
Oh,
right?
absolutely.
Yeah.
Absolutely.
Or get
It's magic
maybe
for that.
If you've had gastritis and it's significant on an EGD,
Yep.
you can discuss if that would be worthwhile to do.
I think if you're in a
Um,
conventional gastro's office, you will just get the PPI. That's their tool.
right, but we
for
want to
it.
talk about when we think it is important to take, right?
I honestly do not have concerns about giving PPIs for a short amount of time.
Yeah.
Somewhere between 6 weeks and 3 months.
Yep.
I think it can make our treatments, our naturopathic treatments work a lot better.
Yep.
I think it can give them pain relief very quickly.
And sleep
and
improvement.
and sleep.
Yep.
And I think it gives us time to do other things that can re-heal the tissue.
Yeah.
So
Right.
I'm not opposed for a 3-month stint.
Yeah.
Am I going to go longer than that? No, I'm opposed for longer than that.
Yeah.
So the only other time I use it longer is if someone is on some combination of prednisone and blood thinners, which some people
Oh,
have to be
yeah.
on for a combo of blood thinners for up to a year after a stent or something like that.
Yep.
it's not standard of care, but it just, the risk of bleeding, I feel like the benefit outweighs the risk for even up to a year in some of those patients if they're on multiple drugs that are potentially going to cause GI bleeding.
The other population that I think is worth mentioning, still short term, is pregnancy, because that heartburn in pregnancy can be so rough. And yes, we try all the other stuff. We have other stuff that's safe in pregnancy, but sometimes that PPI is the only thing. But that, by definition, is temporary. Baby comes out at some point, you get your real estate back. But that's another population I use it.
Yeah, and then for me, it's like a little bit of a no-brainer. Somebody that comes in with acute ulcer-like pain.
Yeah,
right.
Just
start it.
Why
try it? Because it's going to take a while.
Why not?
Yep.
Like there is, I mean, again, cost-benefit analysis. This person's quality of life is in the effing toilet.
Right.
Yeah.
Right.
Yeah.
And if they do have an ulcer, they need that anyway to heal it.
And then, usually I'll start them on the PPI, work them up for H. pylori, and then treat H. pylori, which a PPI is in that standard of care if it's positive, or just maintain the ulcer while I'm doing all of the other things.
Right.
Yeah.
So here's the problem with the PPI. The problem, and especially if the discussion today is tapering, how do you taper the PPI?
Right.
The problem is that acid is very important for digestion. It's important to break down your food. It's important to start the process of absorbing nutrients. It's important to protect against pathogens in your GI.
Bacteria from getting further down, like
and
in the
starting
case
the
of
whole
SIBO.
chain, right? For acid and bile gets
cholecystokinin comes out, and then enzymes.
And the whole cascade gets kind of messed up.
So for digestion and also as a protective barrier,
it's
like
very important. So what the other thing that happens is because acid is so vital for digestion, when you introduce the PPI, the body sees that there's not enough acid. So then it actually double produces the amount of pyloric cells, which are the cells that secrete the acid. Right? So now you're on a PPI, your acid has just gone way down. The body's like, we need that.
Right.
So it makes more PPI, it makes more pyloric cells.
Yeah.
So then if
when
you
stop,
discontinue your PPI, what
rebound.
happens? 3 times as bad heartburn.
We were going to recap why you want to not use them long term too, right? So
let's do that. Why don't you want to use them long term?
Okay. So from the article back in the day, and I'm sure this is progressive.
From your article.
It can affect bone density long term. Community-acquired pneumonia risk, C. diff risk, all of these things, right?
Functional GI upregulates functional GI disorders like bacterial overgrowth, even though there is still some what's the word I'm looking for? Like that's not in the box completely.
Yeah, there's mixed data. I think on SIBO specifically for it. A lot of us have seen that the correlation.
For me, it's
for C. diff, right?
For SIBO.
SIBO.
It's the bone. There's very clear data that it causes an upregulation of osteoporosis.
Yep.
Yeah, and then nutrient deficiency, so B12 deficiency, which if you don't catch early enough can cause irreversible peripheral neuropathy and cognitive
people,
changes.
Like a lot of Americans are already going in deficient of stuff, and people aren't doing their due diligence checking on these nutrients. We do, but a lot of Americans are deficient in these things already. Then we further suppress.
I will also say, the other thing I will say is I don't think conventional docs actually even understand how to read the standard blood work nutrition panel. Like they don't know how to read a B12, which is so cheap.
Well, I don't know about that. I feel like the thinking has changed over the years where I think a lot of doctors will replete less than 400 these days, even though the standard, I don't know.
Yeah.
But I feel like more people seem to be aware that you don't wait till it's less than 200.
I don't see that regularly because I have to tell my patients, like, your doctor is brilliant, knows what she's talking about. And I promise you're going to feel better if we can get your B12 up a little bit more than the 200.
Right.
You know, because I have people who come in at like 206 and their doctor was like, you're fine.
I mean, I also see the other thing where once that B12 range goes elevated on the blood test, the physician gets very worried.
I actually was covering, and I was happy to see that like results letters for patients, the other doctors had said, this is not a big deal. It's not going to cause you any problems, but just FYI, you might.
If you're supplementing.
Right. They were supplementing.
That's the key.
Yeah.
And you might as well do a trial, getting them off of it, making sure that goes down, because otherwise you do need to work up for multiple myeloma, you know, but if you're supplementing, it might be really high.
Yeah.
And there isn't really a danger unless you're out of the ballpark with it, like way too high. But
I don't know of any toxicity from oral B12.
I think you can get something. Yeah. Some nerve issues.
B6
from it.
You can.
Yeah.
Okay. We'd have to ask.
We should look that up.
AI.
Yeah, I think you can overdo it. It's one of the water soluble ones you have to be careful of too much.
Okay, so the risk is definitely osteoporosis, definitely nutritional deficiency, definitely C. diff, potentially Yes.
Yeah.
Potentially functional GI disorders. This is not a good thing to be on.
You don't want to be on it
Yep.
long term.
And
you don't have to.
I also understand why so many people end up on it,
Yeah, it
because
works.
it's effective.
Totally.
And doctors don't want patients to feel worse, and they want to feel like they're doing something.
Yeah.
And so they often give this very effective prescription.
Yeah.
And I will also just say there is now, like literally in the last 6 months, there's this new class of GERD drugs that are about to start coming out. The first one is on the market already in the US, which is a potassium pump.
Yeah.
I don't know
yeah.
about this.
But it's just landed. It won't be on your formulary for like 7 years, so you're good.
So wait, what is it supposed to do differently? Because the PPIs work quite well for what they were designed for.
It affects the potassium channel.
Is it for like refractory cases? Like if people aren't
Yes.
responding to PPIs?
I'm assuming that's what they're getting
Do
FDA
you layer
approval for.
it in? Do you
No,
know?
it's usually one or
You
the other.
swap
And
it?
it just came. I just had my first patient on it. I heard about it when I was getting trained for one of the companies that I work for.
Yeah.
I heard about it back then, and I just saw it in the last couple of weeks. And I was like, I've been waiting for this. Like,
I mean,
know
options
it.
are cool.
What problems is it going to cause?
Yeah, exactly.
So it's actually a drug that's first line therapy right now already in Japan. So there is a lot of data on it. It just has recently been introduced in the US.
Okay.
And it's got a long list of potential side effects. And I don't know what we actually see, because some drugs
is that right? But you don't see a whole lot of problems.
Right. Okay. So that's why we don't want to be on them.
Right.
And then the second problem that we have is once we're on them, and we're on them for a long amount of time, and we want to get off of them, if we just discontinue, your GERD is going to be 7 times worse than it was when you started.
If we do nothing.
Also,
though, I would like to say, you're not figuring out why the person had acid reflux in the first place. Right. Bodies didn't really come into the world ready to like make too much acid. Like that calibration is built into most of us. It's something caused that.
Yes.
And it might be physiologic, it might be microbiome, but like PPIs aren't making us as doctors do our work and figuring out why that happened in the first place.
Well, and they might not even have had elevated acid, right?
Exactly.
It's like 50% of people it's higher and 50% it's lower.
Yeah, or bile.
Yeah.
Bile
other things.
I mean, there are lots of things. There are lots of other things that can cause dysphagia.
Yep.
Let's say you're on a PPI, you've been on it forever, and you want to get off.
Yeah.
How do we do that successfully so that you're not being tortured? Slowly is the most important thing I can say.
Yep.
And so when we prescribe PPIs, there's 2 ways to get them. And I'm talking about omeprazole. I'm not talking about pantoprazole because omeprazole has an OTC, right?
Yeah.
Pantoprazole is for prescription only.
Yep.
Pantoprazole is stronger than omeprazole.
Yeah.
That's why it's the next drug class.
Yeah.
So let's just start with omeprazole because it is an OTC. And so you assume that because you can buy it over the counter, it is safer.
Yeah.
It's not.
Right.
It just had a good lobby.
It's the same mechanism of action.
Same mechanism of action. But let's start by tapering off of omeprazole because then we can kind of extrapolate onto pantoprazole.
If they're on pantoprazole, would you switch them to omeprazole as part of the taper?
My taper prescription wouldn't necessarily change. Like I would still use the same natural agents. I think I would just probably go even slower.
Yeah.
So we are talking, this process should never be fast. Yeah. We are talking about it should take, in my opinion, somewhere from 3 to 6 months, depending on dosing.
Yep.
Can you talk, Dr. Kapadia, can you talk about, one, if you want to do this, how you talk to your physician about it? Let's start there.
Right. So, well, that would be good if that happened. Usually, well, I know that does happen sometimes, but often it's sort of like me looking at the medication list and saying, why are you on this? Do you have any history of Barrett's, etc.?
But you also have a lens.
I know it depends where you're practicing.
So you're doing a lot of convincing on your end, where we get people asking us.
Well, it depends which practice I was in at the time. But so if you are a patient, it would make sense to schedule like a dedicated visit just for this because it's not just like a throw it at the end of 5 other things kind of discussion. So that would be the first thing. And then I think most doctors are open to it because they know now that this is not something you want to keep people on long term. That being said, they might not know exactly what to recommend, but in a standard formulary, there are very simple things you can do. So you could say like, hey, here's some ideas. What do you think? Well, most of the things are over the counter. So, if you're not on it for an indication that's required for you to be on it, you're just on it for symptoms and you want to get off. Some of the things I think about are if you're on it twice a day, going to once a day. If you're on it once a day, trying to go every other day. When you're having symptoms, use Tums, use Mylanta, milk of magnesia,
H2 blockers,
Sucralfate, famotidine. All of these things, I just tell patients don't take the PPI and famotidine like concurrently, but if you're going to start skipping
Why
days,
is that?
I don't know. I might have
Okay.
made that up. So
Okay.
it may be actually
Yeah.
fine. I just have never given people both concurrently long term. So
Yeah.
but it may not be an issue. I just tell them on the days you're not taking
Yep.
the PPI,
Your
you
off
can try
days.
famotidine. On the days you're taking the PPI, if you're still having symptoms, do Tums, Mylanta, milk of magnesia, sacralfate, some combination of those things,
Yep.
and see if you can get yourself gradually tapered down or on an as needed basis, you
And
know?
if you just say that, do you see success with that?
I have given people those protocols, and I've told
Yeah.
them to contact me if they're running into trouble.
For troubleshooting, yeah.
Yeah. And other people are not ready to go off it. It's working great. They don't really want to mess with it right now. And I just try to plant the seed, like, that's fine. I'll refill it for you. FYI, not great to take this for another 10 years.
Right.
If and when you're ready to talk about it, let me know, and we can try to come up with a plan for you to get down on the minimal amount or not that you
I think this is a part where patient education is really important, because people assume if your doctor gave you something, it's safe. And it doesn't mean it's not safe. It's just we in medicine, I think, do a terrible job of informing people about the full context of a lot of these meds.
Now, right? Like we didn't know when we started giving it to
these
people.
longer term studies came out, showing the osteoporosis risk and all of that. But I think we have to kind of sit down with people and say, here's what you're at risk for. And I don't want that for you. And if we can prevent that, we have alternatives.
Yeah. And often they're like, oh, I never knew that. Yes. Thank you for letting me know. And let's try doing something else.
How do we do it? Yeah.
Okay, so let's say we're ready. We're ready to taper the drugs. I think we should be having this conversation in two sections. One, what do you do with a PPI? And two, what are the natural agents that can help you more successfully taper?
Yeah.
Right. So let's have it into those two conversations. So the way that I taper a PPI is I will drop a quarter dose every 3 weeks.
So are you having them cut pills, or are you prescribing smaller, or just getting over the counter?
I think in does it come in more than 2 doses?
So this is it's a complicated question because there's the OTC, which is just a tablet, which is very cuttable. And
it's not extended release?
No, not the OTC.
Yeah, great.
And then there is the prescription that is a capsule with a bunch of little balls.
Oh.
And each one of those balls has a matrix around it to make it extended release. So one of the things
it's
good. Yeah.
Did you just figure this out?
Oh my God.
I called around to the pharmacy.
Yeah. I have done so many tapers of PPIs in particular over my 20 years.
I had no idea that it was like.
I always wondered what those balls were about.
Yep. Each one of those is an extended release ball.
Yeah.
So depending on which product they're taking, if they're taking the tablet, great. We just cut the tablet.
Yep.
Yeah.
If they're taking the extended release prescription, I actually have patients count balls.
Yeah.
And depending on how much they're reacting, we can move it down that slowly.
Yeah, totally.
You know what I mean? Like, and this is something where they were very uncomfortable. They started this prescription. It worked like magic.
Yeah.
They're not in a hurry. I don't want to make them as uncomfortable as when they started.
Right.
So depending on the product they're on, they either count the balls and go down that way, or they do the tablet.
I mean, you could estimate half a capsule, right?
Yeah.
Like if you don't.
It depends on how comfortable you are.
Okay.
And also, I mean, you know this as much as I do. Like,
and your eyesight, I think.
If you don't have the 10 minutes to like count.
Your little magnifying glass out.
Want to count their balls.
That's true. That's
hippies want to say, oh, okay,
it's about half a teaspoon. Yeah.
So so it depends on the product they're on.
Yep.
So I have them drop by a quarter dose. So if they're taking 20 milligrams, we drop by about 5 milligrams every 3 weeks.
Great.
And then so down. And then when they're at 5 milligrams, then I have them take that dose every 3 days, and then for 3 weeks. And then
I never even thought about this splitting of, I just assumed it was like, I didn't take the time, I guess, to call the pharmacy and ask about the formulation. And anyway, go ahead.
So then I have them take it every 2 days, and then every 3 days, and every 4 days. And by then they should be good.
And what are you supplementing?
Okay, so supplement. So the first thing I want to do is I want to give a shout out to Dr. Lynn Patrick. She published this article that literally set the foundation of how I do this.
Yeah.
It was published in the Alternative Medicine Review, which was a phenomenal.
Yeah, that was really good.
It was such a good journal. Right? No, it's not around. It was put out by Thorne, I think.
Yeah, it had the really good gallbladder article.
Yeah, it had the gallbladder.
Yeah.
And it's an article. I'm going to tell you guys the article because this is what I use. It's called Gastroesophageal Reflux Disease, a review of conventional and alternative therapies.
When was it published?
I don't know if I have a date on this.
It's probably like 20 years ago.
It's a review. I mean, if not more.
Yeah.
Yeah. Okay, so it's a phenomenal. She's a naturopath. I think she still works up at the local hospital here in Portland.
No, she's in Colorado, I think.
Oh, she is?
Yeah.
Okay.
And I think she's teaching now.
She is so good.
Yeah, she's excellent.
And she was a researcher and a naturopath.
Yeah.
And so she published this phenomenal article, and for like a second in time. So what this article calls for certain nutrients, right? And there's data behind these nutrients. For a second in time, there was a product on the market that combined all of these nutrients into one product.
Shoot.
I think people didn't understand the value of it, and
Totally.
it got pulled from the market.
No.
So
Bring it back. Bring
It
back.
means that I do have patients putting together
Like 5 things.
like 5 or 6
Yeah.
things,
Yeah.
unfortunately. Yeah.
For the short term.
Yes, but I
Not
mean, it's
super long.
you know,
term.
it's in our population. I'm like,
I
well,
know.
yeah, okay, stop taking this one thing, but now you have to take these 7 things
Right.
and pay for them out of pocket. Yeah.
and pay for them out of
Yep.
pocket. So I know I can successfully get you to taper and give you health benefits in the long run,
Right.
but it's going to take a while to get to the long run.
Yeah.
You
Should
know,
we guess what's in it?
why don't you guys guess what's in it?
I only know the one.
Zinc
No.
DGL.
Really?
No, but there is data on DGL.
So wait, these are
Oh.
nutrients, not like the heartburny herbs.
These are all vitamins and
B12.
Oh.
nutrients. Yes, B12 is on there.
Oh, it's not like, I thought it would be herbals.
There are herbals, but not this. This formulation is not
Okay.
herbals.
Is it regular zinc?
No zinc.
Uh-uh.
Blows my mind.
Magnesium?
No. Ooh, this is a fun
Yeah,
game.
this is a fun game. I got B12.
Vitamin A?
No. Should I tell you guys?
I guess so.
Is
Okay.
it vitamins?
Yes.
I mean, there's only
C.
so many. D.
That's acid.
Okay. I'm going to tell you guys. Eventually,
What
our
other
listeners are
letters?
going to say, this is when I turn off the show. I can't listen to them just yell out random nutrients. Melatonin.
Oh.
So
Ah,
melatonin
cool.
Okay.
at 6 milligrams. Why
Oh,
melatonin?
I can prescribe that.
Melatonin inhibits gastric acid secretion
Yep.
and nitric oxide pathways that will mediate the transient lower esophageal sphincter relaxation. So
Oh.
melatonin makes the LES more active.
And it's a mild prokinetic.
It's a mild
So it's going
prokinetic.
to push things downward rather than going up. That's brilliant.
It also increases bicarbonate secretion for mucosal protection,
Cool.
and it's an antioxidant.
At 6 milligrams at bedtime.
Yep, so 6 milligrams at bedtime is what I'm using.
Yep.
Monotherapy, there is data that 3 to 6 milligrams for 8 weeks improved heartburn, epigastric pain, and complete symptom resolution of increased lower esophageal pressure.
Wow. Is calcium in there?
No.
We should be doing that
Stop
for
guessing.
hiatal hernias too.
Yeah, we should be.
Yeah.
Yeah, we totally should be. Okay, so next. So melatonin is next. The other thing, L-tryptophan.
Yeah.
Why L-tryptophan?
It's the same pack, 5-HTP?
It's a prokinetic.
Okay.
Why
It-
wouldn't you use 5-HTP?
I think
maybe they
tryptophan
just-
is cheaper.
Cool.
Yeah.
You can get it in a powder. That's a hot tip, and just use the powder.
How does it taste?
Fine.
Oh, really? You've tried it?
I don't know. I haven't tried tryptophan, but the other single amino acids haven't been awful.
No, they're actually the single amino acids that I'm using are pretty
yeah,
sweet.
yeah,
Yeah.
So
and they're
this is
cheaper. It's a lot
self-serotonin
cheaper.
pack.
Also, yep.
Tryptophan.
Okay. Vitamins, B12, B6, and folate.
B12, B6,
Okay.
Yep,
folate.
and that
those you
is,
can get in one pill.
yes, those are easy to get. So I would get a melatonin pill.
Yeah.
Yeah,
I get a tryptophan pill.
great. And
I
B
get
complex.
a B complex. And those you obviously want to take in the morning. So tryptophan is 200 milligrams according to the data, B12 50 micrograms, B6 25 milligrams, folate 10 milligrams. Theanine. That one I don't know why the mechanism is there. I'll try to find
As
it.
SAMe or is just methionine?
Methionine. And then betaine.
Oh,
Which I don't know that I would. give
So-
people, but-
This is where the
yeah, I need to hear that
naturopathic
one.
yeah.
this is where the naturopathic and the conventional world divert in a very sharp opposite direction.
Yep.
In the conventional world, the problem is acid, turn off the acid, fixed.
Yeah.
In the alternative world, the problem is that the physiology is not working because there is not enough communication
Mhm.
to give the lower esophageal sphincter information to close. And because that information is not there, because the acid, which is what tells that sphincter to close,
Yeah.
is not there, then you end up with a reflux.
So do you start the betaine and then lower it as they get off the PPI? Their parietal cells are
actually,
making
I-
more.
Decrease the PPI and then increase the betaine.
If they're already making more endogenous acid because their parietal cells are upregulated,
Yeah.
and then you're just dumping more acid, that doesn't cause more symptoms?
I mean, Not
And then
always.
you just
not
taper that down.
surprisingly,
Yeah.
not reliably.
Huh.
I go through. I've been doing this a long ass time. I don't have any other interest. All I care about is naturopathic gastroenterology. You know what I mean? Like, and so I go through all of these waves, and I went through a long wave where I was like, you know what? Has no effing research. There's no research on betaine HCl. I've never seen a
I mean,
study.
it makes sense with hypochlorhydria as we get older.
For sure, in those populations.
I have just seen, and in the last 5 years, good, because of social media, a good handful of people who are like, the thing that made the difference in my life is betaine.
Yep.
Yeah.
Betaine HCl is the one thing that changed my symptoms, or betaine HCl plus B12.
Maybe it triggers some pathway of the whole cascade as opposed to you're actually replacing a significant
That would
amount
make
of the
sense.
stomach
And you're
acid.
doing like one pill with meals.
I'm
to
usually doing
start?
1 to 2, yeah.
Yeah, with
And
meals.
very
And
low
I'm not a
dose.
big fan of like up,
Yeah,
it's gonna
no,
get burned.
No,
I'm not a big
don't
fan
do
of that.
Don't do that.
But it's for a subset of the population, it definitively does something.
Yeah.
And it's cheap. I mean, 225 pills is like $20.
Everything you described is pretty cheap.
Everything I described is pretty cheap. It's just pill heavy.
Yeah.
Tryptophan can be a little bit on the expensive side.
Yeah, I think powders. I think it's the way to go for a lot of these.
Yeah, I think
I'm
I'm
using
gonna
more
try it.
powders.
So those are the nutrients.
Yep.
Okay.
So you get that rolling before we even start decreasing the PPIs?
Yes.
Okay.
I have that going by about a week
Okay.
before we start the PPIs. Okay.
Decreasing the
So
dose.
now let's go on to herbs. If I'm going to do herbal interventions,
Yep.
what am I going to do? You guys, I think you guys will have a better chance at this.
Okay. DGL.
DGL.
Yes,
Are
yes,
you
yes,
considering zinc, carnosine, and herb?
Would probably use zinc carnosine, but it's not in this particular article.
Okay.
There's like the slippery
Marshmallow.
Aloe.
Aloe. Okay.
Yep. So she studied DGL. So there is data about 380 milligrams of DGL basically showed there was a 200-person trial for 28 days. And it showed that there was increased quality of life starting at 7 days.
I mean, that
So-
always seemed to work. That was always my go-to
DGL is
when
awesome.
someone has reflux and we need something quick and we don't go into an in-depth.
And you know what? Can I
Take
tell
it
you
before
guys?
meals.
Can I tell you guys?
I was
going to
ask the
DGL.
dosing. Yeah.
It tastes like candy.
Yeah.
Like
well, I would
licorice
have
is a
them
candy.
do the powder that didn't have all the junk in it, so it was kind of inconvenient.
Me and
They used to have
my
a chocolate
Take
one
it
that was
with
really
you to the
good.
restaurant.
me and my girlfriend would call it dessert.
Yeah.
Like it's a little chocolate chew.
That had so many additives, though. I couldn't prescribe it.
You know what it had though? What else it had? Compliance.
Convenience.
Like, I
It
was
had a
just
lot of
gonna say,
compliance.
Yeah.
Some people were willing to take the powder. With
Is it
them.
as many additives as the PPI?
I mean, word.
That's true.
It does not have titanium dioxide in it.
So wait. You're giving DGL before meals or
That's
just
before
empty
meals, yeah.
stomach?
Before meals and
Okay.
with symptoms.
So like 30 minutes before a meal?
No, I would say
Straight
directly before
before-
a meal.
Directly before a
Yeah,
meal.
I think they would just take it right before.
To
Yeah.
kind of coat the stomach before food plops in and your acid takes over.
Yep.
Or not. acid.
Okay, so it has triterpenoid saponins, flavonoids, and both of those support the epithelial healing via prostaglandin and cytokine modulation.
Okay.
So there is a lot of good data. There's also a DGL-based herbal formulation study that looked at GERD patients over 2 years and it actually performed better than the antacids. Like it's doing more. It has an antacid effect, but it is also healing up the mucous membrane.
Right.
Yep.
Coating and
Aloe has very similar treatments. It's a demulcent.
Mhm.
It has really good polysaccharides and flavonoids.
Mhm.
It protects
Soothing.
the smooth muscle.
Yep.
It's anti-inflammatory.
Glutamine.
wait, is the aloe like that? Like the juice that you buy at the health food
Yes.
store? Is that fine to tell people to
Yes,
take?
yes,
Because
yes,
I always
yes.
get confused. You guys, I can never
The
remember. You
juice
said
is
not
just
to do the-
diluted.
Okay, but you don't do this certain part
You
that's
don't
a
do
laxative.
the whole leaf.
What
Don't
is
do
the laxative
the
part?
whole leaf?
The whole leaf.
Yeah.
Okay.
Yeah.
Okay.
Yeah,
The
you don't.
The
You don't
laxative part is the latex of the leaf.
So just do the aloe. The aloe
The
juice
juice.
is like the
Yeah.
pulp of the.
Yeah.
the juice.
I obviously need to take
The
some
juice. You're just
acid.
getting a diluted product. There's no part of the plant that's juice.
But it's still a reasonable thing. If
It's a
people wanna-
reasonable thing. You're just paying for a diluted product.
So what do you give them then? Pills?
I mean, I get combo products like
Okay.
this.
Yeah,
but
'cause I've only
the
seen it in
gel,
combination.
like that goopy,
The gel, right.
is an undiluted version.
Okay. Of
Yeah,
the good
you just
part
don't
that
want
you
the whole leaf,
Okay.
unless you
Okay.
need to poop. But it's a rough way to go.
And then it's a stimulant.
it's a
laxative,
stimulant
right?
laxative.
So you can
Yep.
get like dependent on.
Yep.
So for the aloe study, 79 patients for 4 weeks were given aloe, and they reported a reduction in heartburn, regurgitation, dysphagia, nausea, flatulence, and it was generally well tolerated.
Yeah, aloe is awesome.
Do you use a single aloe?
No,
product
I'll
or
use
combo?
I'll use a combo.
And it's usually a powder or capsule.
powder.
Okay.
And so the reason why
Right to coat.
because the problem with a capsule is it's coated
Yeah.
until it gets past the esophagus.
Yeah, and you want
Good for
it
the
to be
small bowel, probably.
fine
but
for the small bowel.
we're
Yeah,
but
you
not
want a powder.
hitting
we're
or
not talking
drink.
we're gastroesophageal reflux disorder.
Yeah.
We're talking esophagus.
Yep.
Which is why the juice sounded like a good idea, but I get it. It's
No, I think
diluted.
the
Do
juice
the
is a
gel.
good idea.
Do the
If you're
gel.
going to have juice anyway, get some aloe
Sure.
juice.
The gel is gross. I spent
Right,
many
that's
years.
why I'm wondering.
Yeah, with the gel, and then I
Kinda
would
weird.
put like trifla powder in it.
That sounds
Ooh,
gross,
that seems like
Rebecca.
a formulation.
It worked so well
For
me.
reflux?
Yeah. No, not for reflux. For all the like upper GI stuff I had,
okay.
bloating and whatnot.
Okay.
Prokinetic.
Oh, okay.
But it was disgusting.
The juice is also available everywhere.
Right, it's like over the counter
Yeah.
at
like
the health food
at
store.
Kroger, at
Yeah.
every Kroger
Yeah.
store
Right,
has
right.
aloe vera juice. That there is
That's
something to
why,
be said about
yeah.
grabbing it nice and
Yeah.
easy. Okay, so there is also some really interesting evidence using Artemisia acetaca,
Huh.
which I've never used before.
I've never even
But
heard of that
Nope,
type of
me
artemisia.
neither.
Me neither.
But the study was with 70 patients, 4 weeks, and it showed similar effects to PPIs, but it showed more improvement healing the mucous membranes. And then other demulcents, just exactly like what you said, slippery elm, marshmallow, stuff like that.
And those
Glutamine.
come in teas too. Like
Yes.
Yeah, and that
And
can be really soothing whenever.
They're so soothing.
Yeah.
And that or lozenges, they come in lozenges for
Totally.
like if you're having LPR upper throat stuff.
Yep.
It's very helpful for that.
Yeah, and you can even the chewable tablets that have like DGL in it, sucking on them as a
Yes.
lozenge works well too. You can
Yes.
chew it if you need to, but
Yeah.
sucking on it can really help.
You
Yeah.
said if you have what?
If you have LPR.
Can you talk about that or not today?
I feel like that should be a whole
Okay,
other
we'll do
episode
another
because
episode.
LPR is like GERD on steroids.
Yeah, that's
It's
why
much
I need to
more
learn more about it.
complicated
And
to
they
deal
diagnose it with EGD and various motility
Yeah,
studies.
and it's kind of like a
Okay,
little bit
we'll do
of-
another episode.
Yeah, LPR is a thing that lots of people are suffering with. We
Okay.
see a lot more of it.
Okay.
And so here's what I'm going to say. I think tapering the PPI is super important,
Yeah.
right? I also think that don't do it too quickly.
Mhm.
This is a long game, not a short game. I promise if you taper the PPI too quickly, you will end up getting right back on it and being afraid to get off of it ever again.
Totally
Right.
backfires.
Don't do it too quickly. It changes your physiology. And this stuff is all available, OTC.
And you
Yeah.
can do over the counter medications or you can do the herbals.
Yep.
It's not going to be forever. So
No.
do like have all of it on hand is usually what I tell
Just like a
people, and
10
just use what
pack
you
of-
need, use what's working. I'll also tell people during these tapers, if you get a flare, go back to the week before
whatever dose you were on.
and let things chill out before you taper again.
Yeah.
Like just don't hesitate to slow it down
Yeah.
if you need to, because you'll get better efficacy.
You take the 3 months, 5 months that you need to taper.
Yep.
Because we're looking at keeping you off of it for the next 20 years.
Right.
Right.
Long
So you're
term.
not in a hurry right now.
Yeah.
And let's be honest, engineers do better with protocols like this because
I
you have to be
know.
organized.
Right.
I know. Teachers too.
Yeah.
Teachers do great.
Should we do a quick recap?
Wait. I just want to say one thing.
Yes.
Also treat underlying causes if you
Right.
find them. If your patient has SIBO or something else that's causing that intra-abdominal pressure, like
Yes.
don't forget the underlying cause
Yeah.
because they won't be able to get off of it if you
Yes.
don't treat that. So
And if you don't have any other tools for that, you can use the elemental diet.
call us. Just don't call us.
You can go
Oh,
see.
you're a holistic naturopath.
Yes.
Yeah, that's
Right. And if you are on a formulary and you need to buy something over the counter, what I learned from you guys is I can have someone do the elemental diet.
Yes. Oh my God.
I know that was
Just
a
let's try
great
something,
episode.
you know?
I have used that since that episode,
Yeah.
and it's worked.
Look at us.
Go listen to that elemental diet case. That was brilliant.
Okay. The other thing that I will say is we got some feedback from one of our listeners about something and they were like, refer to a dietitian.
Yeah.
And that feedback was so helpful because now I was like, why would I? Of course I have
I
to
know.
refer to
Yeah.
dietitians. Like
Yeah.
I have my dietitians that I refer to all the time. I
'Cause
can't
who
get
has
into
time to get that
I
much
can't
detail,
get
right?
into the weeds with
Mhm.
diet.
Yeah.
Yep.
That's all they do is diet.
Yep.
Right.
Don't
And
people
I'll
need that guidance? People really
they
need that
do.
guidance.
And I'll ask people about their diet and they'll tell me they're eating healthy. And I'm like looking at their labs.
know.
I'm like, you're not eating healthy, but I can't
relative
figure it
to
out right
maybe
now.
someone in their
And then
house.
like a
but-
few minutes later, like, except for, I eat ice cream every day. I was like, okay, can you go see the nutritionist,
No.
please?
Yes.
and I only drink Coca-Cola.
Right.
And it's just, but I'm like adding in water.
But I
Your
guess
triglycerides are 400.
Or I drink Diet Coke,
Something
which is
going
better.
on, yeah.
Diet Coke is not better, guys. Diet Coke is rat poison plus Coca-Cola.
know.
It's worse.
I don't know if it's worse than
I
the
think it's
sugar
worse.
bomb of
No, no, no.
Coca-Cola.
I-
You think
100
so?
There's
There's
data on it.
aspartame.
There's
I know it's
100%
not
data.
good, but I guess
It's
it
just
depends.
colon cancer. You're gonna get
No,
colon
no, no.
cancer
There is data.
Is there data on colon
Yeah,
cancer?
from Diet Coke.
We're gonna have to look up that
Okay,
data too.
I will tell you.
I don't drink it. I'm just.
I just read a study about it, literally citing how much worse the aspartame, the diet sodas are for overall health.
than
the
regular,
regular
sugar,
soda,
even
yeah.
if you get diabetes.
But they're addictive, and so is sugar. Like it's
Yeah,
all addictive.
it's all
Okay,
addictive.
other episode.
Okay.
Okay.
We're getting on it.
Recap.
There's so many topics. to
Re-
go
re-
through.
recap.
Okay.
Okay, PPIs are not good to be on forever. They have definite indications for short-term use and occasional indications for longer-term use.
Yep.
If you are a patient and you want to try to get off of it, try to talk to your doctor about it. There's easy over-the-counter things you can do. There's also more involved protocols if you want to use all-natural formulations to help you get off of it. There is more diligent and less diligent ways to taper the PPI, whatever.
But you want to taper slowly.
But
Taper
just go
slowly.
slow. That's the key.
And
Yes.
nutrients?
Yeah.
Which one?
B12, B6, melatonin,
Tryptophan,
folate.
Tryptophan,
methionine.
methionine, GGL, aloe, mucilaginous herbs like slippery elm.
Yeah, and I would
marshmallow.
consider
Yeah.
L-glutamine and zinc carnosine.
Yes.
All
Okay,
right.
great. Thanks,
All right.
Terrence.
Thanks,
See you.
nerds.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the turd nerd word.